Good morning, I'm Doug Van Nostren. I'd just like to say I've had the pleasure of working for over 37 years with Dr. Len Wartowski, and I've enjoyed that relationship for all that time. I've been asked to speak to you about risk stratification with radioiodine imaging. And what I'd really like to achieve is to provoke every one of you, each of you. I'd like to provoke you to think about, if you're not doing radioiodine imaging, what is the reason? And the reason usually is, I don't find it useful. But I want to provoke you to go past that and possibly provoke your nuclear medicine physicians and explore the utility of radioiodine imaging. And for those who are already doing radioiodine imaging fairly routinely, not necessarily in all patients, but fairly routinely, I would like to try to provoke you to continually assess how you're performing your radioiodine imaging so that you can maximize the information you're delivering to your endocrinologist. These are my conflicts of interests. So, 63-year-old gentleman, 2.5 centimeter nodule, physical exam, ultrasound, 2.5, solid, no findings really suggesting any pathological lymph nodes, fine needle aspiration done, Bethesda 3, near total thyroidectomy performed. Some might argue with that, but for the sake of the case, this is what was performed. 2.5 centimeter papillary thyroid cancer confirmed on histopathology, and a stimulated pre-therapy radioiodine scan was performed and demonstrated the following. Now, I don't believe I have the ability to direct an arrow on the screens, so I will walk you through this. This is your standard whole body radioiodine imaging, could have been performed with I-123 or I-131. You will see the outline of the head, little activity in the salivary glands, little activity in the middle of the head, the face, which is actually uptake that can be seen in the nose. And there's 1, 2, 3, 4, and I think most of us would agree, focal areas of uptake in the thyroid bed. And so the conclusion or interpretation would typically be most likely normal residual thyroid tissue that any good surgeon might leave behind. Chest is negative, abdomen, there's some activity in the GI tract and possibly some activity in the lower GI tract or bladder. Now, if you look at these images, and as you look at this new set, in the top left is an image that's obtained very quickly. And there are 3 intense areas of chin, suprasternal notch, and XYZ is the xiphoid. And those are radioactive markers to get you localized, since we have very poor anatomical localization on planar imaging. Then we remove those 3 focal areas of activity, and without moving the patient, we re-image the patient, and what we see to the right is several areas of activity. 1, 2, 3, 4, one of them's a little bit higher. Little concerning that that's not in the thyroid bed. I'm not sure what this means. Is the interpretation comes out, you know how they read. It says interpretation : multiple findings in the thyroid bed, most consistent with normal residual thyroid tissue. Number 2, no evidence of distant metastasis. Now, if you go to the lower row, it's a distinctly different image. There's 2 markers, one's the chin, and one SSN is the suprasternal notch. And in that, from exactly the same patient, same day, no additional activity administered, there's 1, 2, 3, 4, 5, and at least when I see this screen here, there's 6, even on the first image. And when you remove the 2 nodules and you take your standard long image, there is 1, 2, 3, 4, 5, 6. Now, most surgeons do not leave behind 6 foci. And we actually know for our endosurgeons and ENT surgeons at MedStar Washington Hospital Center how many they typically leave behind in patients that have very low risk of lymphatic local regional disease. And it's a bell-shaped curve. Typically, it's 3 or 4. Rarely is it 5, almost never is it 6. So if I did the image on the left, the whole body image, I would most likely read this as normal residual thyroid tissue. If I do the image at the bottom, same patient, same day, I'm stopping the process of an I-131 therapy in this patient because I now suspect that there's a good likelihood, despite the ultrasound, remember, was negative, that this patient has local regional disease. And what we do at MedStar Washington Hospital Center, we'll regroup as a team, the surgeon, the endo, the nuke, et cetera, and decide what the next step is. Repeat ultrasound was unremarkable. The TG was 3.5, antibodies negative. The question was active surveillance or remnant ablation. And the real question became, with 6 foci in the thyroid bed and possibly 1 outside the thyroid bed, should we do additional surgery or should we do I-131 adjuvant therapy as opposed to a remnant ablation? Now, regardless of what was done, the issue is the radioiodine scan better stratified that patient and changed what the decision management was going to be, whether one would have done surgery or additional or adjuvant treatment with a higher dose. It altered the management. In this case, the patient did have additional surgery. 6 to 10 nodes were positive. Adjuvant treatment was administered. Instead of a remnant ablation dose, remember remnant ablation is use of I-131 to treat normal thyroid tissue, to make the thyroid globulin valuable. What's most important about that definition is what is missing. And what is missing is there is nothing in the objective for remnant ablation to reduce recurrence, increase progression-free survival, or overall survival. Adjuvant treatment is to reduce recurrence, so adjuvant treatment was given, so it altered additional surgery, adjuvant treatment with a higher dose. And the post-therapy scan confirmed the pre-staging scan with no additional evidence of local disease or distant mets. So radioiodine pre-therapy staging scans can alter management before radioiodine therapy. Post-therapy scans are great. They're not perfect, by the way. Although they're considered to be sacrosanct, they are not perfect, but they're always post-therapy. So the question becomes, how frequently does the radioiodine pre-therapy scan alter your management? Certainly in lower risk patients or intermediate risk patients. Certainly I would encourage definitely in intermediate risk, and I would also personally encourage in most low risk patients. And it's evidence-based literature. Aid, Avram, Barwick, Chepasetti, Gerlings, Gruwall. The list is very long. Now all of these are SPECT-CT articles that have been published showing the value of SPECT-CT pre-therapy radioiodine staging in altering management. 22%, 29%, 20%. But it doesn't stop here. There's Mustafa, Ruff, Schmidt, Spano, Thorpe, Wang, Yamamoto. There's articles out by Cheng and from our lab regarding planar imaging. So why are there so many facilities that will not perform pre-therapy staging scans, and they're good facilities, and why are there so many facilities that say there's value from pre-therapy staging scans? And I think one of the most important single things that's not talked about is technique. Now, we all know a chest x-ray is a chest x-ray is a chest x-ray. Pretty much the same at every institution. And this audience of endocrinologists predominantly, although I know we have some nukes in here, obviously surgeons, but we all know ultrasound is an operator-dependent procedure. We often think when we come to a radioiodine scan, it's a chest x-ray, chest x-ray, chest x-ray. It's not. It's very operator-dependent. And I'd like to make that point and prove that to you. So what I have up here is an image. This is an image of a thyroid bed taken from a whole body image. Now, we use whole body image generically. We say, well, we did a whole body scan. What do we mean by doing a whole body scan? Well, technically, what a whole body scan is, we took an image with a standard gamma camera from the head to mid-thigh, and the patient or the camera moved across the body. And that's how this image was taken. And then I pulled that image from the thyroid bed and I displayed it here. So the head or the patient moved. Now, I stop the camera. I don't move the camera at all. Same collimator, same patient, same day. And this image is obtained without moving the patient or moving the collimator. That has 1, 2, 3, 4, 5, 6 spots on it. When I look here, I'm not sure you see them all on the screen out there because the resolution loses it. I want to emphasize this is the same patient, same day, same camera, same collimator. The only difference that I did is I didn't do a whole body scan. I did, in the vernacular, a spot image. Now, that's a much more impressive image to me than the first image, and in actual fact, that has 6, and that would tweak me to stop and regroup the team on what we're going to do. Now, that's the thyroid bed on a spot image, and here's another image. Now, on this image, there's 1, 2, 3, 4, 5, 6. Maybe you would count that big blob as 2 or 1, but it's certainly 7. So I can see at least 7. Now, nobody leaves behind 7 spots normally. This image on the right is from the same patient, same day, same camera, but has a pinhole collimator on it. Now, I'm not going to take the time, because we have limited time, that on what the dynamics and physics are of a pinhole collimator, but a pinhole collimator has the highest spatial resolution of any imaging within nuclear medicine other than PET. And that information will alter management. There are many other techniques, but I just want to emphasize this one here. This is the whole body scan that you typically see presented at a national meeting. And you see the star artifact, and that's due to a lot of activity there, a lot of residual thyroid tissue left behind by the surgeon. It happens, there's GI activity, and that's the whole body image, and here's the pinhole image from that patient. When you see that star artifact in the future, instead of thinking that's normal residual thyroid tissue, what you need to be thinking is, I can't assess that area. I haven't the foggiest idea what's in that thyroid bed. And I would provoke you then to go to your nuke med physicians and start to have a dialogue. That's a pinhole image, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 foci. Ultrasound was negative in this patient. This was confirmed as local region metastatic disease. That changes management. That changes stage. Image SPECT scan, I won't go through this in detail. You know SPECT's very valuable, most valuable because of its localization. And I just ask, if you get this scan with a pinhole image, so you got chin at the top, suprasternal notch, no activity in the thyroid bed, I would submit to you that you'd alter your management, because why are you giving I-131? And in fact, you might need to give I-131, but you might need to check that TSH, check that urine iodine creatinine ratio or your spot urine iodine. Need to evaluate that further. That stops me from going to I-131. In this case, again, the image has 2 markers on the left with a chin marker and a suprasternal marker. They're removed. You have the image on the right that's obtained for a significant amount of time. That pattern suggests lateral disease to me. It doesn't take a nuke med or a rocket scientist, I don't think, to convince to you all that would raise local regional disease in the lateral neck. Another one, just as I showed 2 cases, multiple foci, more than a surgeon leaves behind, strongly indicative. Now we have excellent endosurgeons, but we have a lot of patients referred from outside the hospital, and sometimes we get a little less than incomplete. That occurred about 2 to 3% of our patients. 4% of our patients, low risk, and this is very consistent with other literature, will have metastatic disease. And this is bilateral increased lung activity, and this is bone met with an intense area over the right shoulder. So these areas I would submit to you alter management, and the frequency has already been discussed with a list of the articles. There's over 20 articles out showing that 20 to 30, 40%, a few of them a little bit higher, will alter management. But there are some additional things on good scanning that will make a difference, and that's this image here. And this is just to provoke that it's not just looking for lymph nodes, not just looking for metastatic disease. There are other things that are important. There's two very circular areas of activity over the anterior chest, and that's bilateral breast activity, patients not lactating. And if I saw that patient and I thought that was pulmonary uptake, I'd be very confident that I could treat those pulmonary metastases, but it's not. It's bilateral breast activity. And I'm fairly confident that I'm going to deliver a very significant rad dose to that patient. So thank you very much. I hope I provoked you on whether to do radioiodine scanning and the reason you're not doing it. And then I hope I can provoke those who are doing it to look at the technique. Thank you.